Hi everyone, and welcome to the 19th and final TA Centre seminar of the academic year. So my name's Adam Shepherd, and I'm a researcher here within the Tissue Image Analytics Centre. For those that are new to our seminars, we invite researchers and leaders in the area of computational pathology and associated areas to discuss their work. And today it's a real pleasure to introduce Andrew Zhang. Andrew is a fourth-year PhD student in the Harvard MIT Health Sciences and Technology program, working in the lab of Dr. Faisal Mahmood at Harvard Med School. And prior to his PhD, Andrew studied cell biology and computer science at Harvard, and his work centers on advancing self-supervised representation learning at multiple biological and temporal scales, from encoding a single pathology slide to encoding entire longitudinal medical histories. And the title of the talk is A Multimodal and Temporal Foundation Model for Virtual Patient Representations at Healthcare System Scale. So Andrew, thank you very much for joining us, and it's great to have you here. So yeah, with that, I'll pass over to you.
Thank you for the kind introduction, Adam. It's a pleasure to be here, and thank you everyone for joining. I am excited to present today the Apollo project, which you all might have seen the preprint for. And we are still actively working on this, and there should be a new version of the preprint dropping soon. So I'll just get started. Medical records contain multimodal and multitemporal data. And this makes it different from um, traditional machine learning for health research, where maybe you're only dealing with one data type, such as like images or notes or tabular data. And so where did like I come from, for example? Like my background in this research in AI for health came from working on images. And if you might have heard or used about other projects that have come from the lab, including Uni and Conch, which are both pathology patch level encoders to encode like a single patch of a whole slide image. Now, the entire trend of the field over the past few years has been trying to scale up, which means to try to capture as much of the patient as possible in a single representation. And so going from patch level, we have scaled up to slide level. And the project I worked on before this one was called Threads, which was a slide level foundation model. And now you have a representation at the level of whole slides. But the dream has always be to get a representation at the level of a whole patient. And to do that, we need to incorporate other modalities. Slides are typically, single snapshots of a patient, and so you can see what is going on in this region of the body at this time. But to capture more systemic diseases and to make more um, comprehensive predictions, you really need to know like what's going on elsewhere in the body and at other times. And so the core part of that is the EHR, where you have all this labs data coming in, vitals, you have interventions, including medications and procedures. And you also have doctor's notes, which are very high density and unstructured impressions of the patient and of their symptoms and of what's going on. So to try to capture all of that data in a single representation, that's the goal of this project. Now, in terms of the technical challenge, this is something that's quite difficult for machines because you have different lengths, sequence lengths for each patient. You have different modalities within each patient. And what machines like to see is kind of like a fixed input size. So the for example, for all the image models, the input size was fixed at, a certain dimensionality, 512 by 512 or 256 by 256. Um, and that makes it like simpler to train and also to do inference. But for when you're trying to capture like a whole EHR sequence, that sequence length is variable across patients. And furthermore, you have this time axis of each event being associated with a particular time. So how do we analyze and make predictions on these? So as I said, our goal is to compress everything into a single representation. And the downstream use cases of this are risk prediction, similarity searching. You can do statistical analysis across whole populations of patients. And you can also assess treatment response. Um, and many other use cases that are unlocked from essentially what is a compression algorithm that runs on the entire EHR. So Apollo is trained on the scale of an entire health system. Um, and we have in total billions of events, many of them coming from flow sheets. And this is spanning over the period of about 30 years um, and around 7 million patients. So to get into the architecture a bit, the the core idea of Apollo is to bring everything into a unimodal embedding space. So whereas previously you had structured data from from the tables, you had text data and you had image data, and these all kind of occupy different semantic spaces. Here, Apollo is trying to get all those modalities to join together into a single space. And to do that, we need individual encoders for each modality, but eventually everything is being brought together into a single embedding space. So for structured data, we learn a lookup table of basically every structured token gets converted into an embedding. And then for text, we use an off-the-shelf LLM. Ooh. Excuse me. This is Gatortron, which is developed by University of Florida and NVIDIA. And um, we, for images, we use a vision foundation model, which is our in-house model, Conch. And so all of this is pre-extracted. And then, at least for the text and images, we pre-extract the embeddings. And then we put an MLP on top of these embeddings. And the MLP is trainable. And then we train the whole thing end to end, including the lookup table for the structured data as well. So as we train this model, you can basically think of it as a large BERT. And what we do is we mask the certain tokens at the output, and we have the model try to reconstruct the embedding. So this is like an embedding level reconstruction. So as we add visits, you can see that there's more and more data coming into the model, and the model is basically trying to fill in the blanks. And this is helpful because EHR data is necessarily very sparse and noisy. And by training it to, try to be robust to this noise, during training, you're also getting it to be just more able to generalize when a modality is missing or when there's records missing from the data. So the way we generate a patient embedding is we insert a prompt, which, because the model is trying to reconstruct these tokens anyways, it takes that prompt and it generates an embedding. And so this prompt is what we use for the majority of our tasks here is a masked diagnosis token. So we tell the model there's supposed to be a diagnosis event here and try to predict that. And so the model generates an embedding at that point, and that is what we call the patient embedding. And of course, you could prompt with like different tokens as well, but what we found was that diagnosis is typically, because so many of our tasks are disease-related tasks, the diagnosis prompt typically does the best. So these this patient embedding is what we use for all these downstream tasks. And eventually we hope to unlock early diagnosis, treatment response prediction, dynamic risk scores, clinical trial matching, all of these different use cases, and then plus population health use cases, including biomedical discovery, and identifying like new disease clusters. So this is a UMAP of all the learned event level embedding. So as I said, the Apollo model compresses the patient timeline in two steps. The first step is to compress the individual events into embeddings. And then all the event embeddings come together to create the patient embedding. So what we refer to here as an atlas of medicine um, is a clustering of all the unique structured medical events and colored by medical topic. And so what you see here is that uh, these are completely learned from scratch, these embeddings in the lookup table. They cluster naturally into these semantically reasonable clusters. And if you zoom in, you can see that they align very well with what clinicians would consider to be related tokens. So here, if we zoom in on the diagnosis tokens, we see that diseases of the eye are clustered together, circulatory diseases are clustered together, and lymphomas are clustered together. But what we also see here is that we're not just simply recapitulating, the existing ontology. So here is the ICD-10 ontology. We also see these more emergent clustering, such as the burn and corrosion to the eye, clustering with eye diseases rather than clustering with the other um, injury and poisoning chapters. And what this shows us that the model recapitulates, is aligned with these existing ontologies, but is not limited by them. So um, it can learn its own decision boundaries between what's related and what's not. Similarly, for medications, you have immunotherapies clustering together, diabetes medications, and also HIV medications. And here, glucose, you can see glucose in the diabetes cluster, and this is because glucose is a lot of times administered as a test for diabetes, and so it shows up under the medications cluster. And so what this enables us to do is create a visual fingerprint of every patient. And by plotting every event of that patient in a single UMAP on top of the UMAP that you just saw earlier. So here we are plotting medical events from the medical record of a single patient with chronic myeloid leukemia. And what we see here is different modalities really coming together and associating with each other in this unified space. So the stars here, the different colored stars, map to the same color star on the UMAP. And so here you can see the blood smear, these are images, mapping very closely in the embedding space to these hematology lab tests. All these dark green dots are hematology. And these lab tests show leukocytosis, and these blood smears also show evidence of that. So similarly, you have these bone marrow biopsies and cytogenetic findings. These are mapping to here on top of the hematology background cluster here, that's in dark green. And then you have all these vitals and more macrovascular tests showing up in this cluster here. So basically, all these different modalities you can see are mapping to the same embedding space. And with that, you can uh, basically get a unique fingerprint of this patient. So no other patient will have um, a event structure that looks like this. And already you can start thinking about applications towards similarity searching and how this can be compressed into a single patient vector. So we take these event embeddings and the model compresses it all into a single patient vector. And so we see if we plot that, we get this patient level UMAP. And now the patient level UMAP exhibits clusters of its own. So these clusters are defined by what is the major disease afflicting this patient? Usually, what is the major ongoing condition? Um, and what we see is that, first of all, there's an age gradient, a very obvious age gradient, where it goes from younger time points on the right and older time points on the left. And we also see that healthier patients generally cluster towards the middle. You can think of it in terms of if you're from like the cell biology or stem cell space, these are more undifferentiated cells. And then patients who have a very clear phenotype kind of go off towards the edge, towards their own cluster. So we have clusters for breast cancer, for blood cancer, skin disorders, etc.
Andrew, I think I've got a couple of questions in the chat, if that's okay.
Oh yes,
Um,
of course. I haven't been keeping an eye on the chat.
oh no, don't worry, not at all. So,
Let
so
me.
Shazad has just asked if patients with rare disease can be identified from the dense data as such. Do you want to expand on that at all, Shazad?
Yeah, I mean, it's hugely informative data sets, and obviously within that data set, you may have patients with rare genetic conditions, and obviously you've got small numbers, and if that with cross linkage with trials, other bits of data, can patients be identified? Is my question. How robust was the identification process of that big data set?
Oh, right. Okay. So for de-identification, we have um, a a model that basically removes the PHI from the doctor's notes, and uh, that model is currently like being validated, and we will potentially release that. I'm not sure yet, so that we will have more to say on in the future. And so for rare disease, for rare tokens, what we do is we don't train on like tokens that are super rare. So of course, if you have the exact timeline of a patient, every patient's timeline is unique, right? So if you think about identifiability in those terms, then yes, then if you see the timeline and you already know the exact timeline of the patient, then you would be able to recognize it from that timeline. However, in terms of the HIPAA definition of identifiability, we remove all those identifiers from the data.
Brilliant. Thank you very much, Andrew.
Well,
Yes.
We've also gotten, sorry, a third question.
So I think
Yes.
when you were talking about taking the different modalities into embeddings, I think you mentioned that the image modality was being embedded by conch, which is a patch level embedding model. So if I understand it rightly, then when you have the image modality, your model sees it essentially as a sequence of patch level tokens. But I know you have like some slide level models as well. So I was just wondering, I guess you had the choice when you were designing this to go with a sequence of patch level tokens or a slide level embedding token. So I was wondering how you decided between those two?
Yes, yes. Well, so for this version of the model, we trained on we used Conch, and that is because Conch is a very multi-purpose encoder. So, it can understand not just pathology images, but also these hematology images and EM images as well. And that is kind of why we used it for its flexibility, and we just averaged the patch level tokens. Now for the cytology images I showed earlier, each of those images is very tiny, and those can, easily fit in just one patch. Um, so uh, yeah, so those can easily fit in just one patch. So we didn't see much of a problem there. But in the future, yes, it would make sense to use maybe like a slide level model, like Threads or Titan for the pathology images, and use the patch level model for the smaller images. Okay, so I have the chat pulled up now. I see there's another question. Are you able to identify patients' data or data from different sites using the embedding? So sites here, the definition of sites, I think, is a little bit tricky because each patient may go to multiple sites. So I think in our data set we have like 17 or more different like hospitals. But each patient can kind of show up at multiple hospitals. So it's all kind of mixed together, and we don't see clear clusters in the patient embedding that cluster by hospital.
Thank you very much, Andrew, for answering all our questions there.
Okay, so the next thing I'd like to talk about is the applications of Apollo to search. And so once you have this patient level embedding, you can use it for semantic similarity search, which previously was not possible. Previously, to identify some cohort of patients, you had to manually match using some pre-selected criteria. And here, you can see that across some different cohorts, which were identified with SQL queries, Apollo generally performs better than using the last progress node. So the closest to being able to do patient level similarity search is just taking the embedding of the last progress node. And the last progress node contains the most comprehensive detail about that patient. It includes, labs. It includes things that the doctor thinks is important about the patient, as well as typically a summary of the entire course of disease. So we benchmarked against that, and we show that particularly in oncology, our model does a lot better job at retrieving patients with the similar disease and also treatment profile. And here are some more detailed examples of similarity searching. So besides searching using a patient, we can also search using a image or a text. Really, you can search using any modality because the model brings all the modalities into a single embedding space. And so here, we search using a text description of clinical trial inclusion criteria. Now, this is relatively simple, but we have three main inclusion criteria here. And so those are history of atherosclerotic disease. We have a LDL cholesterol threshold, and then we have a statin therapy criterion. So of those, you can see just searching using that text string, we can match patients that satisfy all those criteria, going from the text embedding to the patient embedding. And so this is very exciting because this means that the model has really learned that all of these embeddings have, all these modalities have gone into the same space. Similarly, we can search using images as well. So if we search using a pathology image, this is from TCGA. So this is actually out of distribution for the model. It's a slide that is from a data set that the model has never seen before from a different institution. And what we find is that the retrieved patients match not only the diagnosis, but also the grade and the molecular subtype. And this is very impressive, especially the fourth patient here. This is ordered in terms of similarity. This patient actually does not have a slide in their health record. So this is only purely matched based on the rest of their EHR timeline, including notes and reports and all of that. So now some of the more quantitative results. So we have like 3 different classes of tasks. So these are all framed as time to event tasks. So the model is making some prediction at some time point of when an endpoint might happen. So the first category is we're trying to predict new onset of disease. And so for this, we start the prediction at a hospital discharge time. And then we try to predict when or if a disease will appear. And to make sure our model's not just learning like the easy factors like age and sex, we have this simple baseline, which is in orange here. And this is just showing like how much, just using like the most basic demographics factors, how much performance could you get? So and as you can see here, our model is better than the age and sex baseline, which is good because otherwise we would have done all this work for nothing. But you see that any additional performance here is due to the other features that are taken in by the model, like the other details from the EHR. We also have a category of disease progression where the index time is the time of diagnosis of a disease. And then the endpoint we're trying to predict is a disease-specific endpoint of that's showing like the disease getting worse, basically. So mortality, for example, is an endpoint that we use for several of these tasks. We also have endpoints that rely on certain like treatments coming into place. So certain treatments can indicate that the disease has really progressed to a worse state. Yeah, and then we also have different forms of the same disease. So for example, chronic kidney disease, you can go from a 2+ to 3+ to 4+. And then finally for treatment outcomes, age-sex baseline. So I just see a new question. So can you expand on age-sex baseline definition? It's literally as simple as it sounds. It's just training on using only 2 features. So whereas the Apollo model generates a 768-dimensional feature vector, and then we're training this survival prediction head, right? Well, I call it survival, but really it's just the generalized form is just the time to event prediction head. Instead of training on the 768 features, we train on the just 2 features, age and sex. So for treatment outcomes, the index time is the time of first administration of a medication, and then some outcome that we predict. And these outcomes are sometimes quite difficult to extract from the EHR because they aren't necessarily coded in like a structured way. And so a lot of our outcomes are just survival because that is the most reliable. Death is one of the more reliable, reliably structured codes. So we can basically try to predict survival. We can try to predict survival, how long a patient would survive on this medication at the time of their first administration. And so one thing I want to point out on the treatment outcome task in particular, these are associational predictions, right? So the model is I'm not making any causal claims here. In fact, it's it's really impossible to make any causal claims here without the some proper like causal inference techniques or having the counterfactual. But what this is showing is that uh, the model is essentially learning to stratify patients generally in using like prognostic factors. So a lot of these are basically prognostic factors. Um, and so I see another question here. So age is a measure of frailty. Yeah. So yes, you can think of age as a measure of frailty. Yes, and so that would already help in this prognostic task. And then sex is just because some diseases are sex specific, so it would help to know, especially like things like breast cancer. And we have a few tasks here that's just like more acute endpoints that we refer to as clinical operations. So these are usually tasks that would be relevant in like a emergent or urgent setting. And then for like length of stay and readmission, these are relevant for inpatient settings. So so we show that yes, we can also predict these acute endpoints and these operations endpoints. Just as a highlight, the cancer endpoints here. So cancer is one of those task categories that we thought it was important to drill down more on because it's one of the physiological, it's one of the diseases that's the most physiological complex and potentially can benefit the most from having this kind of like multimodal whole patient data available. And so we have several tasks here. We have predicting melanoma mortality, prostate cancer, chronic myeloid leukemia, and we can predict these with an AUC of pretty high. As well as for these survival tasks, we have um, uh, the survival on these monoclonal antibodies and these other drugs for breast cancer and prostate cancer. And the AUC on these is pretty high as well. So we constructed just a 30 task benchmark that's only on cancer progression, and we tried to see just how much the we tried to compare different versions of the model and try to get the effect of the ablations as well. So we compared the full model with the structured data only, and we also compared it with a fully supervised transformer, as well as just predicting using the last progress node and then using the age-sex baseline. So as you can see here, the pre-trained models, both the full and the structured only model, perform a lot better than the fully supervised and the other models, which shows the benefits of having seen all of this data from other unrelated patients, basically. And furthermore, comparing between the full model and the structured data only model, we also see a jump in performance. Now, this jump is maybe like not as big as we would like, but this could probably point towards the way that we're encoding these unstructured data points, these unstructured events, including notes and images, could probably still use some more tuning and some redesigning as well. So, but at least with the simple way that we are incorporating these data, with the off-the-shelf encoders compressed into these event level embeddings, we do show that it confers a benefit to the model. So Apollo does a really good job at stratification. That's kind of its whole thing. It stratifies patients for these tasks. And you can see that for these mortality tasks in particular, the stratification is quite good. And we also assess the calibration of the model. So here, when the model predicts like a risk score, so stratification just requires that the risk scores be ranked in the correct way. So a patient that is more likely to get the disease sooner has a higher risk than a patient who is less likely. And that's what stratification requires. But for calibration, it requires that the absolute risk score is actually calibrated to the real life probability, the observed probability that, this endpoint would happen. And so this is, we show the calibration is also pretty good on these cancer tests. Finally, we look at the biomarkers and try to interpret how they contribute to the predicted risk. So as a case study, we show this patient who eventually is diagnosed with invasive breast cancer, and we show how different events in this patient's timeline over time contribute to an increasing risk. And so these ages are all shifted, so this is not like the real age, but it's all shifted by just a couple of years, so it's relatively similar. So here we have at first the increase in risk coming from a right breast fine needle aspirate, which is suspected to be a cyst. And then the bilateral mammogram. The BIRATS2 is normal, so probably the slight increase in risk from this mammogram can just come from it being a certain age proxy factor. So patients who at a certain age they get mammograms, and then their risk also increases just as a function of age. So we see a really big jump here from when we see a left breast cord biopsy with ductal carcinoma in situ and lobular carcinoma in situ. Now this makes sense because technically it's a carcinoma. It's still in situ. It's not invasive yet, but obviously it can progress to invasive. And so that's why we have such a big jump here. And basically this is where eventually at here in this timeline at around age 65 is when the patient is diagnosed with the invasive breast cancer. Although they removed you can see here they removed it with clear margins. So another example here for a patient with was eventually diagnosed with lung cancer. We see a large jump in risk from the carcinoid tumor of the left upper lobe. And there is on CT, you see a stable right upper lobe ground glass nodule that also increases the risk. And then we have a note coming in that's saying this patient is a former heavy smoker and has a family history of lung cancer, and that obviously causes the risk to increase as well. And then we see that the right upper lobe nodule is slowly enlarging, which makes it suspicious for lung cancer. And so this is where sort of the model is predicts that a pretty high risk score. And a lot of this is also just sanity checking the model to make sure that, although we still cannot make any causal claims here as saying like these events are the cause of an increased risk, we can at least check to make sure that they are consistent with our understanding of physiology and medicine. So this shows that the model, although this risk, graph is not exactly smooth and there's a lot of noise in it. It shows that overall it makes sense from a clinical perspective. I see another question. Can Apollo risk scores identify subgroups that will do badly? So for example, stage 2 colorectal cancer that will develop distant metastases and therefore it will benefit from adjuvant chemotherapy. Yes. So this is kind of the disease progression test that I showed earlier. So where it's at the time of diagnosis. So when this patient is diagnosed with stage 2 colorectal cancer, it can predict um, it can predict basically what is their risk of developing distant metastases or any metastases. Um, and then after you stratify patients in that way, then you can decide, whether the high risk patients will benefit from chemotherapy. So at the population level, we can also show uh, certain biomarkers and how they contribute to the overall risk. And so this is in terms of like absolute contribution. Um, I would like to highlight a few examples here. So for progression from COPD to respiratory failure, we see these biomarkers that point to a cardiopulmonary strain and also iron deficiency. And um, the cardiopulmonary strain, I think, is um, pretty uh, pretty obviously associated with COPD, but the iron deficiency is something that's maybe a little more subtle. But actually, after we looked in literature, we did find some references that point to the association between um, iron deficiency and COPD prognosis. Same for the progression of heart failure and acute kidney failure. We see that there's a lot of skin and nail disorders. And so there's some papers in literature that describe how skin and nail disorders, how cardiac diseases can sometimes manifest in as skin and nail problems. And that might be a reflection of what we're seeing here. And then finally, for the progression from type 2 diabetes to the diabetic foot ulcer, we see these macrovascular biomarkers, including needing multiple insertion attempts for lines, drains, airways, and as well as atherosclerosis and gout. And gout in particular is associated with worse outcomes for or increased probability of getting a foot ulcer. Um, so that concludes the slides, and the QR code here just links to the original LinkedIn post from my PI. And so I'd like to thank my PI, Dr. Faisal Ahmood, as well as my teammates, including my co-first authors, Tong and Sophia, who are not here today, but they have been also instrumental in getting this first version of this preprint out the door. And we are all working hard behind the scenes to improve it and and uh, and come out with the next update soon.
Fantastic. Thank you very much, Andrew, for a really, really interesting talk there. So yeah, let's open the floor to questions. Does anyone either online or in person have any questions they'd like to start with?
Is the data set accessible?
Yes.
So I think the first question was about the data set, Andrew. Have you heard that?
Yeah. So the data set is not currently accessible. We're exploring ways to make it, or parts of it, accessible in the future. But as you can probably guess, this is going to take a lot of work to ensure it is safe to release. Both, I mean, if you look at how long it took Mimic to release their data, right? It's really it took like a multi-year effort from releasing, just a few dozen patients to, more and then thousands, and now there's like, tens of thousands of patients. But we have to go through a rigorous process of, making sure the identification is good, and then making sure there's just it's safe to release. So yes, we will hopefully have more news on that in the future, but as of right now, it is not accessible.
Okay, so hopefully potentially some of it in the future. Okay, brilliant. And I think so. Can I also ask as well, was the radiology data included in this particular pipeline?
Yeah, so radiology images, we're not. We don't yet have access to radiology images, but we do have the radiology reports. And so a lot of these
Okay,
modalities, they're included in terms of their diagnostic reports, um, which I would say, contains most of the clinically relevant information in the reports. The advantage of looking at the raw images comes from maybe being able to identify certain biomarkers that clinicians haven't really identified as being important yet. And so at that point, you're doing more of this like knowledge discovery thing, which is a little bit, I alluded to that in this in the population level biomarkers here. It's, maybe a tool for hypothesis generation, and then you can go and validate some of these biomarkers. But yeah, but for now we include the reports.
thank you. And also another question about I think at the start when you talked about using conch for the patch level embeddings. So I think you said that you take the average over all the patches instead of doing any form of multiple instance learning. Is there a particular reason why you took that particular approach, or?
The reason is simplicity. So I think a lot of times, as we've shown them in our pathology works, mean pooling is a formidable opponent to beat. A lot of times, like just the mean pool of all the patches, does pretty well. So just to make the model like tractable, to train, to make it simpler to extract embeddings, for now we just take the average.
Sure.
But that may change in the future.
Okay. Yeah, there's another question. That's it.
Hi, Andrew. First of all, congratulations on great work. So very quickly, what percent of the total number of patient records are histology? You have 25 billion records. Not all of them are histology, of course.
Yes.
I guess my question is what percent of the total number of patients and the total number of, just roughly, total number of records are histology images that are processed through this pipeline? And then same question for the bioinformatics type of data as well. Do you only take the mutation calling from the records, or do you process the original sequencing data?
Yeah, we take the mutation calls from the that are in the reports. So for your question on the histology, so I am going back to the preview. So in total we have like 1.1 images, 1.1 million images. I think if I remember correctly, around half of those are histology.
Okay.
But yes, I think around half of those. That's actually here, no, 300. So 311,000 is the pathology whole slide images. Yes.
Okay. And going back to Adam's question about radiology, you only use the radiology reports. Is that right?
Yes.
Okay, great. Thanks.
Thank you, Nassim.
Thank you very much. So do you have any, I think we've got another question on the chat. So the question was, have you compared the effect of leaving out all images? So just using the
yes. So that is our ablation in the slide I showed earlier for the oncology here. The oncology benchmark here. So we left out all the images and plus all the reports, and we see that's the structured data only baseline.
Sure. Thank you. And I suppose a quick question on this point as well, Andrew, is I think it's AURC that's what we're saying here. Would C-index be a better measure to use for this particular task?
Yeah, so this is actually like a very interesting question here. I think I've seen for these time to event tasks, there's many different ways of reporting the results. You can binarize it. What I notice a lot of people do, some papers do, is they binarize the task into predicting will the patient get let's see, will the patient die within 5 years, or will the patient not die within 5 years? And they only take patients who die within 5 years or patients who have at least 5 years of records. And they make it a binary test. Now that's simple to train, simple to report. However, it does ignore the problem of right censoring, where a patient's record ends before 5 years. So now you're essentially excluding all those patients, right? If you try to binarize it that way. And so the reason why we opted for a time to event benchmark model here is time to event is the most comprehensive framework for dealing with this the censorship, the right censorship in particular. And then when we report the result, we can binarize it when reporting the result. So what this AURC I'm reporting is, it's the UNO's cumulative dynamic AURC, which is essentially saying for all pairs of patients who one of them is gets the endpoint before your threshold. Let's say in this case for melanoma, let's say it's 3 years. If for a pair of patients where one of them dies before 3 years and one of them survives longer than 3 years, does the model predict a higher risk score for the one that got the endpoint before that threshold? And so that's the definition here. This is essentially you train with censorship in mind, and then when we report, we binarize it just for ease of. I mean, everyone knows what an AURC is, so that's why we use that metric. We do have C-index as well. We do report the C-index for everything in the supplement. It's just AURC is just a nice and palatable way to describe what the model's actually predicting.
Sure, thanks, Andrew. And I think there's also another question from Akash on the chat. He's asked, for oncology, have you compared leaving out the pathologist reports and only including the histology images?
No, we have not compared that yet. There's many different ablations that we could do with maybe we only include certain medical fields, we only include like radiology reports, only includes. So there's kind of many different versions of this model we can train. Right now, it's just the limitation on time and compute, and yeah. But that would be an interesting experiment to run.
Yeah, absolutely. Okay, then I think there's no more questions online, or I think we do actually. Okay, so I think we've got another question online as well from Shazad, who's asked, will the whole histology archive of each patient be analysed? For example, a patient with synchronous or metachronous cancers. So it's about using. Sorry, did you get that, Andrew?
Sorry, I'm getting a bunch of notifications. Sorry.
So it was about using multiple histology images per patient.
Yes. Sorry, could you repeat that question?
Sure. So the question from
blowing up.
No, that's okay. So the question from Shazad was, will the whole histology archive of each patient be analysed?
The whole histology archive. It is the histology images that we have access to, which may not be all the histology images that are available. At least like it's the ones that have been scanned. So a lot of these images these slides are not scanned. And in that case, we don't have access to them. But yeah, but it's the 300,000 images that we have access.
That's amazing. Okay, then. Well, I think we'll draw the seminar to a close then here. But thank you very much, Andrew, for a really, really interesting seminar and for answering all the many questions that we had for you. So
Yeah.
Congratulations on this brilliant piece of work.
Thank you so much, and thank you everyone for taking the time to listen to my presentation. Yeah, if you have any other questions, feel free to reach out. And yeah, thank you, Adam, for this opportunity.
Thanks, Andrew. Thank you, everyone.